Okay, good afternoon, everyone. Welcome to NeuroTalks. Today we have two very special guests, Professor Clarençon and Dr. Kevin Premat. They are both interventional radiologists at the Pitié Salpêtrière, a very close to my heart hospital, as far as I've been there as a medical student working in the same building. They are working now. So it's a pleasure to have you both here and joining NeuroTalks. So today, the topic for today is thrombectomy in large vessel occlusion. And our panelists today have been publishing extensively on these and other matters. And so it's a pleasure to have you both here. Kevin, I think you are starting.
Yes.
I will start the first slide. So I would like to thank very much Dr. Thiago Batista for this kind invitation. And it's a pleasure to present this NeuroTalk today. So as you told us, we will speak about acute ischemic stroke, and specifically we will talk about rescue stenting in the setting of refractory large vessel occlusion. So Kevin, who is a fellow in my department, published recently a meta-analysis on this topic. So he will start this presentation, and I will move on clinical cases and discussion about dual antiplatelet therapy.
Thank you.
Thank you very much, Frédéric, and again, thank you, Dr. Batista, for the invitation. So yes, I will talk about those cases of refractory occlusions. So as you know, as operators, now we know we can help so much these patients. It's always very frustrating to have an unsuccessful reperfusion, and what we defined to be those refractory occlusions, which means refractory to the standard mechanical thrombectomy techniques such as aspiration or stent retriever. So in the randomized trials of 2015, it represents unsuccessful reperfusion represents around 10 to 30% of mechanical thrombectomy cases. So it's quite a lot actually. What we mean by refractory occlusions are not the TC2A, but more the TC0 or 1. So the occlusions that you cannot recanalize through standard mechanical thrombectomy means. And in the THRACE trial from 2016, it still represents around 20% of MT cases. So quite something that is quite frequent. The main problem with those refractory occlusions is we know by experience that the prognosis is usually dramatic, and this is something we are going to see. The main risk factors that you have for those refractory occlusions are, of course, intracranial atheroma. It's up to half of the cases usually, and the other causes for refractory occlusions are the clot composition. If you have a calcic clot or a fibrous clot, it might be very hard to remove. So this is an example, a case that's which is the rationale for such techniques, which is rescue stenting. This is the case of a 62-year-old male with endocarditis, has right hemiplegia, acute, NIHSS 22. As you can see, no lesion on the FLAIR imaging, but you have an infarct on the diffusion, superficial and deep Cillian territory due to an M1 occlusion. So at this point, this is your typical mechanical thrombectomy. You don't see anything that seems difficult, no special tortuosity. It should be all right, but it doesn't go that way because 11 passes later you cannot obtain significant recanalization. As you can see, you have still regain a small insular branch, but nothing very significant. It's basically all you have done is push the clot even further, and you are here and you cannot recanalize the patient. You have to stop the procedure before causing even more harm. So of course, the prognosis is dramatic. It's quite a young patient, around 62-year-old. He is neurologically unchanged at 24 hours and severely disabled at 3 months. So yes, a very dramatic prognosis of unrecanalized intracranial large vessel occlusions. So this is the numbers that we will talk about later. The prognosis of those refractory intracranial occlusions, it's around 30% mortality. So leaving an M1 occlusion, for example, it's around 30% mortality, and only 21% of the patients are able to achieve independence at 3 months. So the prognosis is very, very, very poor, and we know as operators, which makes it even more frustrating. So one of the way we have to salvage such refractory occlusions is rescue stenting, which has been more and more tried in the latest years. Problem: you need dual antiplatelet therapy, or at least a quite aggressive antithrombotic regimen. So the risk is very high, especially at the acute phase of an ischemic stroke, but the reward is potentially very promising, because you can recanalize the brain and salvage the ischemiated brain. But is it legitimate? This is something we wanted to explore, to see if we should implement this in our everyday practice. So rescue stenting was previously used when we were doing thrombectomy before the stent retriever era, before 2008. It was used with quite good results. Dual antiplatelet therapy is mandatory to ensure stent patency. Problem: you have a risk of hemorrhagic complication, especially at the acute phase, and also when you have an underlying intracranial atheroma, which is very frequent in those refractory occlusions, you expose your patient to the risk of reperfusion syndrome. So this is an example that we did in the beginning of the year, I believe. This is a severe intracranial atheroma. As you can see, severe stenosis of the ICA termination extended to the proximal A1 and M1. So we did angioplasty, balloon angioplasty first, and then stenting. The result is good, and the patient wakes up perfect. He has no symptoms anymore. But at 24 hours, you have a very poor blood control of the blood arterial pressure, and you have a major hematoma secondary to the reperfusion syndrome. So potentially the risk is very high, and the consequences are also dramatic, especially under dual antiplatelet therapy. Also, we have a high proportion of intracranial atherosclerotic occlusion in these cases. So the thing is, maybe we should treat those intracranial atherosclerotic occlusions just like coronary occlusions, just like the cardiologists do it. Because as you know, in cardiology, direct aspiration and things like that have been proved inefficient. So maybe we should treat those occlusions just like coronary occlusions, with a combination of aggressive antithrombotics and stenting at the acute phases. Of course, the underpinnings are not quite the same, and the hemorrhagic risk in the brain is much, much higher. So in this work, what we wanted to explore is try to see what was the best strategy between these two strategies, which are in everyday practice. This is something we do every day. We want to know if we need or not to stent. So we wanted to compare the usual care, which is simply leaving the intracranial occlusions when you cannot recanalize it through a mechanical thrombectomy, through standard mechanical thrombectomy means. So you leave the occlusion with no further endovascular treatment, and the patient is only medically managed. Whereas the second strategy, which is the more aggressive one, you try to recanalize at all costs using rescue stenting, dual antiplatelet therapy, or at least an aggressive antithrombotic regimen, and also the best medical management. So those are the studies that we could gather. So mind you, this is a meta-analysis, comparative meta-analysis. So when you seek to do a comparative meta-analysis, all the studies that you include must be comparative, must have a control group of unrecanalized patient inside the study to be able to compare and pool all the patients. So we have 352 patients. This is your typical thrombectomy population, around 70 years old. The median NIHSS is between 15 and 20. You have mainly anterior circulation occlusion, but also you have 4 basilar artery occlusions. What is, in my opinion, quite important to notice is the aspect score that are quite high, around 8, 9, and the infarct volume in the third study, which are very low. So probably there is an over-selection of the stented patients in these studies, which may hinder the interpretation of the clinical outcome. So these are the results from the meta-analysis. So first, the overall rate of successful reperfusion. So among the patients that could not be recanalized through the standard mechanical thrombectomy means, the overall reperfusion with stenting was 71%. So which is quite good. And in terms of clinical outcome, so this confirms, first, this confirms that the unrecanalized patients suffers from a dramatic evolution. As you can see, only 1 patient out of 5 is able to achieve independence at 3 months. Whereas with rescue stenting, it goes up to 43%. 43% this is the results you have, for example, in the main, the main 5 randomized trials. So results that are almost as good as the standard population of mechanical thrombectomy. In terms of mortality, prognosis is also very, very poor in the unrecanalized group. As you can see, 31% of mortality, and it goes down to 19% with rescue stenting. Those results are very, very impressive. There is not so much interventional techniques in all medicine that have such good results. And what about symptomatic intracranial hemorrhage? So even though the difference is not significant, you can see that on the contrary of what you would await, the rate of symptomatic intracranial hemorrhage was actually lower in the rescue stenting group in comparison to the control group, which is surprising because you used dual antiplatelet therapy. You would think that the rate of hemorrhagic transformation would be higher, but actually it's quite the opposite. It seems that the main risk factor for hemorrhagic transformation is actually unrecanalization and not dual antiplatelet therapy. Now you can note that those rate of symptomatic intracranial hemorrhage are very high in the Hermes pooled meta-analysis, for example, it's around 4 or 5. So we are in this meta-analysis around 3 to 2-fold higher. So this confirms the disastrous evolution of unrecanalized large vessel occlusions, with only 1 patient out of 5 able to achieve independence, 31% mortality. I insist, it's a very, very poor prognosis with unrecanalized patient, but I'm sure you guys have seen it in your everyday practice. And the aggressive strategy with rescue stenting and the dual antiplatelet therapy, we cannot exclude that the antithrombotics are part of the benefit of this strategy. This strategy seems very superior and very, very promising. And also we have less symptomatic intracranial hemorrhage, even though we added the dual antiplatelet therapy. Of course, there are many limitations to this study. First, the observational nature and the limited amount of patients limit the extrinsic value of the study. Then the 43% of good clinical outcome with rescue stenting seems, in my opinion, very, very optimistic, especially considering those cases are often very hard technically and require long procedures. So it seems to me that, yes, it is very, very optimistic. Probably the reason is that only people with small volumes of ischemia were selected in these studies. Also, there is a big heterogeneity across studies and across countries when talking about the antithrombotic protocols and management, and also the additional interventions that were used besides rescue stenting, such as balloon angioplasty or adjuvant pharmacological treatment. Those are very, very heterogeneous across studies. Posterior circulation occlusion have been very fewly studied on only 4 patients. We can't really draw any conclusion about that, but still in clinical practice, we see that patients with basilar or vertebral artery occlusions, they often benefit the most from rescue stenting. They probably have a smaller infarct, so less risk of symptomatic intracranial hemorrhage, and also the initial presentation is often very, very bad. So there is a lot to win. And also, only patients within 6 hours from symptoms onset were included in this meta-analysis. So beyond 6 hours, nothing has been tested. Frédéric, you're on mute.
Yeah. No, yes, we can't hear you. You are mute. Yes. Perfect. Yeah, perfect.
Sorry.
Thank you.
So as Kevin told us, these patients are highly selected, so with a high aspect and a low volume of infarct, and only within the 6 hours after the symptom onset. So I will move on more recent studies. These studies that has been published by a colleague from Germany and Switzerland. So they focused also on rescue stenting in refractory occlusion, but they focused on patients with a moderately severe stroke, so with a NIH lower than 10. So they included 41 patients in this study, and they had a very high recognition rate with a definitive stenting, with a low symptomatic intracranial hemorrhage rate around 5%. And which is very interesting is that they evaluated the early neurological improvement, which is defined as a decrease of the NIH score of more than 4 points during the hospital stay. And this early neurological outcome improvement was observed in about 50% of the cases. And at 3 months, about 75% of the patients had a good neurological outcome. And this group, so these different centers from Germany and Switzerland also published this series, included more than 200 patients, also patients with refractory occlusion treated by rescue stenting. And in this series, they evaluated the predictor for a poor clinical outcome after the rescue stenting. And what they showed that it was that the patient with a higher NIH score at admission had a worse outcome, of course. Patient with a pre-mechanical thrombectomy, high MRS had a worse outcome. And also they showed that if you have no recanalization after the stenting, so MTK 0 to 2A, the outcome is worse. So if you cannot recanalize with the definitive stent the occlusion, the outcome will be poor usually. So what about the rescue stenting in real life? So a first example of a 63-year-old female who presented a sudden onset of hemiplegia. So the NIH score is of 12. on MRI, you can see this pontine infarct on the right side, and on the MR angiography, you can see that the basilar artery is not visible. So the patient was referred for mechanical thrombectomy, so we confirmed the occlusion of the mid aspect of the basilar artery. We performed 3 passes of mechanical thrombectomy on this basilar artery occlusion, and you can see the control DSA shows a partial localization of the basilar artery with a probable underlying stenosis or a residual thrombus in the basilar artery. So if you leave the basilar artery like this, maybe it will reocclude and you will have a bad outcome. So we waited a couple of minutes to see if the occlusion will reoccur, and you see we have a reocclusion of the basilar artery. So you have no choice, you have to try to reopen the vessel. So what should you do before doing the rescue stenting? First, you have to do the cone-beam CT acquisition in the angio suite to rule out any hemorrhagic complication, because if you have a perforation or if you have an hematoma, it's too risky to put a stent with a dual antiplatelet therapy. So first, the cone-beam CT acquisition, and you should also do the stent retriever test. So you have to deploy the stent retriever and to do a run to see if the stent retriever reopens the vessel. Here you see that there is too much tension on the microcatheter, so there is like a squeezing of the vertebral artery. So you have to release the tension when you do the stent retriever test. So this is not a good way to do this stent retriever test. And here, when you release the tension, you see that by deploying a stent, you will have a good reopening of the vessel. So the stent retriever test is good in this case. So you can put the definitive stent, the rescue stent, to keep the vessel open. Of course, before doing this rescue stenting, you have to load the patient with a dual antiplatelet therapy. So we will talk about it later on, but it's important to give the patient antiplatelet therapy to avoid reocclusion of the stent. And here you can see the result after the deployment of the stent. It was an Atlas stent, which was deployed in the basilar artery. And you have here the CT angiography, which has been performed a couple of days after the procedure. And the patient had a very good clinical outcome with an MRS of 1 at 3-month follow-up. A second example of rescue stenting in a 53-year-old patient who had this acute ischemic stroke on the right side. So the patient was referred 7 hours after the symptom onset. The NIH score was 7. And you can see that on the MR angiography, you have an occlusion of the M1 segment on the right side. So the patient was referred for mechanical thrombectomy. So you can see the occlusion site of the M1 segment with this temporal branch just before the occlusion. After a first pass of thromboaspiration, you see that you have just a TK1 localization. You just have a little longer segment of M1, which is recanalized. We perform 3 other passes of thromboaspiration. So we recanalize the M1 segment, and we can see here the cortical branch of the MCA. But if you see on the oblique projection, you have a residual stenosis. So is it a stenosis? Is it a residual clot? So you wait a couple of minutes and it will reocclude. So we will do 2 other passes with a combined technique, combining Sophia and Solitaire. You recanalize the vessel, but when you wait a couple of minutes, it will reocclude. So here it's a good candidate for definitive stenting, for rescue stenting, because you have a reocclusion and a reocclusion because probably there is an underlying stenosis and you have to put a definitive stent in this patient. That's what we did. So we navigated a microcatheter and deployed an Atlas stent to cover this stenosis. And here you can see the result at the end of the procedure. And here the complete recanalization of the MCA. There was no A1 segment here. And so complete recanalization of the MCA. And you can see the CT scan performed 2 days after the procedure. So there is a deep infarct, there is a small infarct, but the patient, we avoided the huge infarct of the MCA territory. So the patient had a good clinical evolution. So what about the dual antiplatelet therapy? This is the key point, because we are all afraid to have like hemorrhagic complication, catastrophic hemorrhagic complication. So here are the data from the studies which has been included in the meta-analysis of Kevin. So in most cases, the operator injected IA or IV anti-GB2B3A, so during the procedure, and after the procedure, most of the series, the patient received dual antiplatelet therapy for 3 to 6 months and one antiplatelet therapy for all their life. And in our department, we use another strategy we use for more than 1 year now. We use the Cangrelor, which is a P2Y12 inhibitor, which is injected IV, and it's very interesting because the half-life is very short. So it's a kind of on-off medication. If you inject it, it will be active in a couple of minutes, and if you stop the infusion, the IV infusion, it will stop the effect. So if you have a huge hemorrhagic complication, you can stop very easily and very quickly this antiplatelet therapy and to stop its effect. So we recently published this series of focused on the use of Cangrelor in acute stenting for acute ischemic stroke. We included 12 patients in this series, either for cervical stenting or intracranial stenting in 50% of the cases, or both stenting, intracranial and cervical stenting. And our protocol was as follows. So before putting the stent, so a couple of minutes before putting the stent, we inject a bolus of IV aspirin, 250 milligrams. And after, we inject the bolus of Cangrelor. So it's a bolus of 30 microgram per kilogram. So this is the bolus that we inject 10 minutes before putting the stent. And after, you have to inject an IV continuous infusion of 3 microgram per kilogram per minute. Okay, and you have to be very careful about this infusion, because if you stop the IV infusion, the effect of the antiplatelet therapy will stop a couple of minutes after. So in this series, we had a good results in terms of recanalization. All the patients were recanalized. The outcome was good in about 60% of the cases, and we had only 2 hemorrhagic complications, and only 1 was symptomatic, a symptomatic intracranial hemorrhage. And the key point is when you switch from Cangrelor, so we leave the Cangrelor for 1 or 2 days, 24 to 48 hours, and after we switch for ticagrelor, and the hemorrhagic complication we had, the symptomatic hemorrhagic complication we had, was during this switching from Cangrelor to ticagrelor. So here an example of our management of this dual antiplatelet therapy. It's a 44-year-old female who presented a right-sided hemiplegia, sudden hemiplegia. The NIH is 22, so you can see here there is a small infarct in the insula on the left side. You have this left MCA, which is which presents a stenosis, and when you look carefully, you have the pattern of dual lumen, which is very suggestive of dissection. So here you have the DSA, and so the patient was loaded with a bolus of IV aspirin, so 250 milligrams, and we injected before putting the stent the bolus of Cangrelor, and after the continuous infusion of Cangrelor, so it's 4 micrograms per kg per minute, and after we put it the stent, and the patient was left under Cangrelor for 48 hours, and after we switched from Cangrelor to ticagrelor. So here you have our protocol. So as I told you, you have to use as much as you can 2 antiplatelet therapy, so IV bolus of aspirin, and in our department we use Cangrelor as a second antiplatelet therapy during the procedure and during the 2 days after the procedure. So as I told you, the Cangrelor is a P2Y12 inhibitor, which is reversible. And the main benefit of this medication is its on-off action. So it's very quick. The onset of action is very quick. And when you stop the Cangrelor, a couple of minutes after the stopping, the effect of the Cangrelor will stop. So our strategy is, this is our protocol. So if the patient don't receive IV TPA because we are out of the time window, the patient has, during the procedure, heparinization, so IV heparin during the procedure. And if we have to put a rescue stent, the patient is treated by aspirin, so IV bolus of aspirin, and Cangrelor, so with the bolus and then the continuous infusion, and we stop the heparin during the procedure. If the patient receives the IV TPA, so the risk of hemorrhagic complication becomes higher. So we evaluate the risk of hemorrhagic complication in patients who receive IV TPA. What are the risk of the high risk of hemorrhagic complication? The main risk are if you have a low aspect, because you will have a large infarct and you have a higher risk of hemorrhagic transformation. And also if you have an incomplete recanalization, the risk of hemorrhagic complication is higher. So if this risk is, we think that this risk is low, we use our protocol with aspirin and Cangrelor. And if we think that the risk is very high because of the low aspect, we use only one antiplatelet therapy. We perform a CT at day 1, and if there is no hemorrhagic complication, we put the patient under aspirin and ticagrelor. So, as I told you, we use IV aspirin during the procedure and Cangrelor, and after we will switch the Cangrelor for ticagrelor. Why do we use ticagrelor instead of Plavix, for instance? Because ticagrelor, the risk of resistance is almost 0, so you do not have to test the patient before. So we switch the Cangrelor for ticagrelor, 90 milligrams twice a day orally. So, but we have to do, before this switching, a CT to be sure that there is no hemorrhagic complication and not to put the patient under ticagrelor if there is an hemorrhagic complication after the procedure. So, if the patient has a high risk of hemorrhagic transformation, so as I told you, a low aspect or an incomplete recanalization, we will switch from Cangrelor to ticagrelor only with a half dose of ticagrelor. If the risk of hemorrhagic complication seems to be lower, we are switching Cangrelor to ticagrelor the day after or 2 days after the mechanical thrombectomy. And after, we put the patient under dual antiplatelet therapy, so aspirin and ticagrelor for 3 to 6 months. And after, the patient is left under aspirin for all his life. So here, another example of rescue stenting. So it's an example of what you should not do, because we did some mistakes, and we had the patient had a good evolution, good clinical outcome, but it was not the way that we should treat this patient with the rescue stenting. So it's a 62-year-old female. She had a slight aphasia and a facial palsy. The NIH score is quite low. It's an NIH score of 4. So you can see some small infarct on the DWI, and you can see this very severe stenosis on the distal aspect of the M1 segment of the MCA, which is confirmed by the CTA. So you have a near occlusive stenosis of the distal aspect of the M1 segment. And so we discussed with a neurologist, and we suggested them to put the patient under dual antiplatelet therapy. And a couple of days after, the patient had a very slight clinical worsening under dual antiplatelet therapy. The NIH score is now 6, so the infarct is a little bit more extended now on the DWI, and you see we don't see anymore the stenosis. We see an occlusion of the distal aspect of M1, and on this swan-weighted image, you can see that there is a thrombus at the junction of M1 and M2 on the left side. So the patient was referred for mechanical thrombectomy. So the patient was already under dual antiplatelet therapy. So we tried first to recanalize, to remove the clot with 2 passes of aspiration, which didn't work. And we tried to do a combined technique with a preset and ACE catheter, which didn't work as well. So we did this stent retriever test. which was not very good. It was the first mistake we did, because you don't reopen very well the vessel with the stent retriever open when you do the run. So we did this first mistake. Maybe we should have performed first an angioplasty and not put the stent as a first intention. So we put it an atlas stent in the M1 segment, but you see the stent is a little bit too far, and the proximal aspect of the stent opened inside the stenosis. So we tried with very difficult, with a lot of difficulty to recatheterize the stenosis and recatheterize the stent. We put it a second stent inside the first one, which reopened a little bit the M1 segment, but it was not perfect. We tried to recatheterize with a microguide wire in J-shape to try to do a balloon angioplasty, but it was very difficult. And gradually, the M1 segment reoccluded. And we decided to stop the procedure and not to be too harmful, because we had good collateral. So hopefully, in this patient, we did some mistake, two mistakes. First, the stent retriever test was not good, so we should not have do a balloon angioplasty before putting the stent. And second, the stent was put it too distally, and we should have put it more proximally. But we were a little bit lucky in this case, because the infarct didn't extend it, and the patient had a good clinical outcome, because she is MRS2 at 2 months, so maybe she will improve. So what about the comparison between the need for balloon angioplasty and stenting? So what are the advantages of balloon angioplasty? It will help to reopen severe stenosis, and you don't need any dual antiplatelet therapy. So you will avoid the risk of hemorrhagic complications. You will reduce this risk at least. The main drawbacks of balloon angioplasty is that you don't know the diameter of the parent artery that you will try to reopen. So maybe you can oversize your balloon and you can rupture the artery. Also, you don't know really what is the site of the stenosis. You have an occlusion, but you don't know where is the underlying stenosis. And also, as I told you, you have a risk of rupture if you overinflate the balloon. If the balloon is too big for the parent artery, you have a risk of rupture of the parent artery and catastrophic outcome. And you have also a risk of reocclusion if you don't leave a stent in the stenotic vessel. For stenting, the advantages of the stenting, it's usually easy to deploy, and it will keep the parent artery open, because you have a mechanical force, the radial force of the stent. The main drawback of the stenting is that you need dual antiplatelet therapy. Sometimes you have a risk of misopening of the stent, as we had in the previous case, and it could be sometimes very difficult to recross the stent. Another point that should be discussed is how many passes should be performed before the rescue stenting. Should we put the stent after one failure of mechanical thrombectomy, after 10 failure? So we have to read the literature to know what is the best strategy. So the literature showed us that beyond 3 passes of mechanical thrombectomy, the risk of hemorrhagic complication becomes very high. So if you do more than 3 passes, you have a significant risk of hemorrhagic complication. And also beyond 5 passes of mechanical thrombectomy, the risk of futile recanalization is increases. So maybe you will recanalize after 8 passes, but it won't have any effect on the clinical outcome. So in the literature, there is no consensus about what is a refractory occlusion. Most of the authors are according that with the fact that after 3 passes, it could be a refractory occlusion. And sometimes even after the first pass, if you see that there is obviously an underlying stenosis, maybe you should put a stent, a rescue stent, instead of doing many passes. Another question about the rescue stenting is which patient are the best candidate for rescue stenting. So the patient with a large core infarct are not good candidate for rescue stenting. Also, when you do the cone-beam CT acquisition in the angio suite and you see that there is evidence of hemorrhagic complication, this is not a good candidate for rescue stenting, of course. So you should do this CBCT acquisition in the room to rule out any hemorrhagic complication. And also, you may have some cases like this. The calcic cerebral emboli, they are not very good candidate for rescue stenting. I will show you a case we had. And you will see that you cannot put a stent in this kind of patient. So it was an 88-year-old female. She underwent a carotid endarterectomy, and just after the intervention, she awoke with a deficit with an NIH score of 3. So she was referred for MRI. You can see the small deep MCA infarct on the right side. On this T2 star image, you can see the blooming effect. But when you look at the 3D TOF MRA, you can see this very strange image. You have like a filling defect in the MCA, M1 segment of the MCA. So it was a post-operative stroke. So we moved the patient to the CT scan because we are a little bit surprised of the aspect of the clot. And in fact, it's a calcic embolus. You can see you have like a piece of stone, which came probably from the endarterectomy, which is stuck inside the M1 segment of the MCA. So the patient was not, the deficit was not huge, but they asked us to try to remove this calcic embolus and to do the thrombectomy. So you can see here the DSA at the beginning of the procedure. So you have this non-occlusive calcic embolus in the M1 segment. And we try first to do aspiration with aspiration catheter, but you can see the embolus, it's here. It's bigger than the lumen of the aspiration catheter. So impossible to remove it by aspiration. So we try to cross the calcic embolus, but you can see it's very, very hard and it's very difficult to go between the embolus and the wall of the parent artery, and a little bit risky with the microguide wire. And we tried a lot of combinations. So we tried a combined technique with the stent retriever and the aspiration catheter. So you can see the embolus is here. You can see it. It's radio opaque on roadmap, but we were not able to remove it. So now it's an occlusion. Now the embolus is responsible for an occlusion. So we have to try to remove it as much as we can. And so we tried a longer stent retriever, but the embolus is here and it also failed. I will show you. So the embolus is moving a little bit, but it was impossible to remove it. And so you see the embolus is here, and we have a combined technique with the stent retriever, but the stent retriever is slipping along the embolus, and it's impossible to grab it with this combined technique. So it's a little bit like at the fun fair. It's very difficult to grab the toy. So we try all this combination of techniques, and so you can see stent retriever, combined technique, aspiration technique, dual stent retriever technique, and it didn't work. So when I presented this case at different congress, all people told me, okay, you have to put a stent to stent the MCA to push the calcic embolus. But I think it's not a good candidate for definitive stenting because it's even difficult to cross the embolus with the microguide wire and the microcatheter. So by putting a stent, you are sure that the stent won't open at this level. So in my opinion, these patients are not good candidates for rescue stenting because you have a piece of stone in the M1 segment and it will be impossible to open the stent. Another people told me that maybe I should have performed an angioplasty, but here, if you do an angioplasty, you are sure that you will rupture the parent artery. It's because the calcic embolus is too big and it's very difficult to cross. And if you inflate a balloon in front of the embolus, you will rupture the artery. And here, this is the roadmap at the end of the procedure. You can see this ugly sign, which is contrast material, which is along the sulci of the brain. And so the occlusion stayed, the embolus could not be removed in this patient. And unfortunately, the patient had this deep hematoma due to all this manipulation we try to do to remove this calcic embolus. So definitively, in my opinion, this kind of calcic emboli are not good candidate for definitive stenting. So in conclusion, we know that when we cannot recanalize the occlusion, usually the outcome is very bad. Fortunately, this rate of non-recanalization becomes lower and lower. Now it's 10% of the cases. And the rescue stenting seems to be promising when you cannot reopen the vessel. So when you have a refractory occlusion, this rescue stenting seems promising. You have to use a dual antiplatelet therapy. So there are different protocols. I showed you our protocol, but it could be debatable. And this rescue stenting improves the clinical outcome. You have a higher rate of patients with a good clinical outcome, and you reduce the mortality rate. And you don't increase the risk of hemorrhagic complication. But as Kevin told you, you have to be very aware about the fact that all the patients that have been included in our meta-analysis had a low volume infarct and have had a high aspect score, and they were all within the 6 hours after the symptom onset. Thank you for your attention.
Well, thank you both for your brilliant presentations. It was really, really interesting to see what you are doing, and you are definitely in the edge of interventional radiology. So I'm really glad that you could present these today. Well, there are many questions. I think some of them are similar, and also. Maybe I would have the same question as well, because we were used some years ago to think of intracranial atherosclerotic disease, and we would think immediately of wingspan. And you are not using wingspan at all, not even you are using coronary stents with balloon-mounted coronary stents. So why Neuroform? That we know that is a very easy to deploy stent.
Yeah.
But does it have the enough radial force? I know it has, but why?
The main problem is we don't have anymore the wingspan on the market in France, because, you know, with the Sampris study, we almost don't perform any stenting for ICAD. Except for acute ischemic stroke. So the wingspan is not available on the market. So that was the only stent we can use, our stent we use like Neuroform Atlas. And for the balloon-mounted stent from cardiology, it's an off-label use. So if you have a complication, it could be difficult to explain why you use this.
Yes, of course, yeah. Yes, well, I know many countries that still have a wingspan, and Portugal is one of them. But I agree that Neuroform is a very familiar stent, and also very easy to deploy. And so, but the other question that is more or less in the questions that I've read already, and I also have. If you have a thrombus in M1, distal M1, you don't exactly know where it is, and you mentioned that it would be difficult to predict where the occlusion is, and also you don't know if it's going to one of the branches of the MCA. So how do you choose which branch are you going to deploy the stent in? The upper branch, the lower branch. How do you decide that?
Yeah, that's the benefit of the stent retriever test, because if you are in the good branch, you will reopen the M1 and the bifurcation. If you are not in the good branch, you won't reopen the second branch in which the clot is remaining. So the main point is the stent retriever test, and if the stent retriever test is not good, it could mean that either the radial force is not enough, or you are not in the good branch. So in the case I showed, the stent retriever test was not good, and maybe we should have performed before putting the Atlas stent. We should have performed a balloon angioplasty.
Okay. So when are you doing in real life? When are you doing a balloon angioplasty before deploying the stent? Just if you don't have a good retriever, well, a good stent response in the test that you do. Is that correct? So you do the balloon angioplasty if the test is not good.
What we do, we use a getaway balloon, and we use the smallest one. I think it's a 1.25 millimeter, and we are increasing the diameter of the balloon. But we don't use a big balloon as a first line, because my main concern, I saw it when I was resident, is to explode the parental artery, which is a game over.
Because, there is a question about that from Tiago Lorga. He's asking if it happened to you, not with the balloon, but with the stent, with wire probably. It happened to you to perforate one of the arteries when you are trying to deploy, because you don't really know, or it might be difficult to see where it goes.
We didn't have this complication, but you know, everything can happen. But normally, the one of the main advantage of the Atlas Neuroform, it's very easy to deploy. Children could do it. It's you know, it just unsheath the stent. So the main issue is you have to be sure that you are not too distal, as in the case I showed. You have to put the stent in front of the stenosis. But otherwise, it's not difficult to deploy.
When you put the stent in the basilar artery, you are not afraid of occluding the perforators, are you?
Yeah, you know, you are in a total rescue bailout. You cannot leave the patient with a basilar artery occluded. So it's better to have some perforator occluded than having, you know, leaving the basilar artery occluded. But yeah. I agree that you can push the clot along the wall of the basilar artery and occlude the perforator. But one of the advantages of the Atlas stent is it's an open cell, so you know the mesh are not very tight. Or the risk of pushing the thrombus is a little bit lower. But I agree, it's a risk.
Yeah. So Dr. Singh is asking if advanced CT perfusion is helpful, indicating about underlying atherosclerosis of the intracranial vessels. Yeah, it might be. I also agree. Dr. Tarek is asking, well, some part of it you have already answered, is also asking the correlation between the reperfusion injury, such symptomatic intracerebral hemorrhage after rescue stenting, and aspect score. You mentioned that if the aspect score is very low, it's always a risk, but it's also a risk for carotid stenting as well, if you have to do it. And a couple of questions more, if you have time. Any role for interprocedural calcium channel blockers, vasodilators?
You mean for vasospasm?
Well, to vasodilate the vessel.
Why not? But maybe if you recanalize, you increase the risk of hemorrhagic reperfusion. Maybe, I don't know, but
yeah. He's also asking about for how long do you keep under antiplatelets, but you have answered already, and also the session will be offline. So if people want to, I'm sure many people would like to see it again. And about Leo baby stent, any experience?
Yeah, we didn't try, but it could be an option. You could use Enterprise, you could use Atlas or Leo. It's up to you. We use Atlas because it's the radial force is good. It's lower than wingspan, but we don't have any more wingspan in France, and it's very easy to deploy. So
yeah. And what about the solitaire AB? The one for the carotid artery.
It's an option. You can use the solitaire AB and detach it, but we don't have it in my department. But it's a good option. You can do the stent retriever test, and if it's good, you just detach the stent. So it could be an option. Yes.
Yeah. Dr. Jada is asking, so you don't leave protection wire before stenting? No, you have to take this. There is no wire. So
no.
yeah. So any success with coronary stents? Many people interested in coronary stents.
Yeah.
Okay, I think
they are not very easy to navigate, and you know it's an off-label use. So
yeah, and difficult to put in the intracranial arteries. I guess. Well, I'm not going to. Well, there are some other questions, but I think many of them are already answered. And so again, thank you so much. It was a pleasure. It was a
thank you for your nice invitation.
Thank you very much.
And that if you have 1 more minute, I'd just like to announce next week that will be the last one before holidays. It will be about next week. Will be about the endovascular treatment for deep and severe cerebral venous thrombosis. That we know that there are some. It will be with Professor Jonathan Cotin from Amsterdam, and he has recently published a really good paper on these. It's a multicentric study, and he will share with us all the results. So I think it's going to be very interesting as well. So again, thank you so much, and see you very soon. Hopefully,
see you soon in Congress or in Paris.
Yeah, exactly. Yeah. Thank you. Bye bye.
Thank you very much. Bye.
Bye.